Hey class, it's Dr. Dorf. Want to do a lecture over knee pain. We're going to focus on one thing that you will see commonly in the clinical setting that will baffle you. And it's a very common, it's not even an injury, it's probably one of the most frequent presentations of knee pain. And you'll do a workup for it, and you'll get essentially a benign or boring exam, and you will be absolutely stumped, thinking you are the absolute worst practitioner in the world, when that is not the case. It is just something that you really haven't experienced before at the bedside. Now that we're making the transition over to the provider role, it's something you'll encounter frequently in the clinical setting and in practice. This is also reinforced on my PowerPoint presentation under your learning modules. That is the knee in primary care. Anyway, going to get past some of the stuff you guys are able to read on your own. One thing I do want to show you guys in talking about plain films, anyway, for knee, not so much MRIs, but just plain films. There's your standard two-view knee, which is an APN lateral. And then you'll also see things commonly referred to either as a three-view knee series, or you'll see knee two-view with sunrise. The sunrise is this last one here. This is when you're looking, isolating pretty much right at the patella. In fact, sometimes I've seen on plain films where you don't even get this much of the femur into it, and you're really just kind of looking at the patella. Hence, they're shooting it from, they put the x-ray directly above the patella and shooting from straight above. Anyway, so this is a sunrise view. That's your standard two-view right there. This is what's included in a three-view, or sometimes you'll have to order it as a two-view with sunrise. So that's what you want to get when you're just isolating the patella, or in the setting of arthritis or trauma. I would typically recommend getting a three-view. Well, I would, so would guidelines. But anyhow, all right. So what we're going to focus on is this, the routine office visit, the routine clinic visit. You have someone who comes in, and this can be all of your differentials that you're thinking of when the patient comes in. You see knee pain pop up on the board or on the chart. Of course, we aren't diving right into neuromas and so on and so forth. But anyway, this is all stuff to, it's kind of running through your head. What I want to point out here is this, Patellofemoral syndrome, PFS, or sometimes you'll see it referred to as PFPS, Patellofemoral pain syndrome. Either way, or sometimes you'll even see it referred to just as PFP, Patellofemoral pain. Most commonly, though, it's going to be PFS, Patellofemoral syndrome. As you can see, in patients 20 and under, it is by far the most common reason for a office visit with a complaint of knee pain in an atraumatic setting. 95% of the time you're going to have that. You will also see in the adult population, ages 20 to 48, you can see right here, number 1 on the list is also your patellofemoral syndrome. So this is going to be someone who comes in and like I said, usually it's atraumatic. It may be acute in terms of onset of the pain, but there's usually not going to be trauma involved. And they're going to come in, they're going to talk about how they're having this pain. They're going to point all around their kneecap or their patella. One of the keys is typically with patellofemoral pain syndrome, they're going to have more anterior patellar pain, but we'll get to that in a minute. Also, typically, if you're getting a good history, which I know you all do, you will usually find, because this is an overuse issue, and is very common in runners. It's very common in people who have just started running or started exercising in general. In fact, in the military, this is the #1 thing that shuts people down during boot camp. when they first get into the military, because all you do for the first 6 weeks of boot camp is nothing but running. You run, 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 run. You march, then you run some more, then you do ruck marches. And people that have not been preparing for that properly will develop patellofemoral pain. So you can have pain that presents anywhere around this area, around the patella, when they are pointing to it. Usually it's going to be below or anterior. And you can see here anterior, thinking patellofemoral pain syndrome. So here you go, a 16-year-old comes in, pain for 1 month, kind of just rubbing all around the knee, the front of the knee when you ask them to point to the pain. They say that it hurts when they go up and down stairs, so that it gives out. Anyway, so you're going to find that there's not a whole lot going on in terms of examination. The key here is the quadriceps when you're dealing with patellofemoral pain syndrome. Reason being is that our quads support and control the majority of the knee, especially the anterior portion of the knee. So a lot of times, and you need just going back and thinking back to anatomy into your assessment class. Keep in mind that anterior knee, even proximal knee, you're going to be dealing primarily with quadriceps and quadriceps tendon and quadriceps in general. Like I said, supports the knee just how our core supports our back. So, like I said, this is an overload, overuse sort of issue. You will have, and a lot of times it's due to the fact that there's not a lot of strength in the quadriceps. There's deconditioning. This talks about atrophy or tightness of the quadriceps. So one thing that I will typically do in the clinical setting is I'll put my hands around the patient's quads and ask them to engage or flex their quads, and can typically feel a difference in the between the affected and unaffected side. Another easy way to do this, in fact, this is recommended in terms of guidelines, is have the patient squat, because 80% of patients that have PFS are going to experience pain when they do a squat. They'll probably be able to go down just fine, but they're going to have difficulty pushing back up on the affected knee. You may also see if they're wearing shorts, you'll see where that quad just doesn't quite engage as well as the other, and you may even notice a little trembling or some shaking. So that's really what you're focusing on with PFS. Your overall examination in terms of what you've been trained to do running through a knee exam, in terms of your anterior and posterior drawer test, Lockman's, varus and valgus stress testing, McMurray's, all of that's going to be negative. It may be positive in terms of causing some pain or discomfort, but it's going to be negative in the sense of you should not experience or find joint instability with any of those tests. Again, this is going to be a history thing. It's going to be really kind of focusing on the quads. And again, you can do apprehension test. Basically, with the apprehension test, you're going to have the quads relaxed, knees going to be flexed about 30 degrees, just like you're going to be doing a drawer test. And you'll apply some pressure to the medial portion of the patella, and you'll try to push it laterally while looking at the patient's face. If they give you that look that they want to come flying up off of the exam table and kick you in the face, that's probably a positive apprehension test. It's not all that sensitive, though, only about 35 to 40% in terms of sensitivity. Anyway, you're not going to order imaging for patellofemoral pain syndrome or PFS. Just not indicated. There's nothing structural that's going on. It has to do with the quads again. Now, if there's trauma involved, of course, you're going to go ahead and order plain films. But for the most part, not. You're going to focus everything utilizing, of course, rice therapy like we mostly do with musculoskeletal, but everything needs to be focused on quadriceps strengthening and stretching. In fact, I have a handout that I give to my patients that present with this. That focuses just solely on exercises, stretches, and things they can do at home, nothing crazy you got to go to the gym for. That'll help to build up the quads. As they strengthen their quadriceps muscle, then the pain goes away. You may also read something about theater sign. This is a very old school thing. It's going back to the 1930s and 40s when people got the news, not from TV, of course, at that time, but from going to watch a movie. And beforehand, they'd run these real clips of the news. So you'd have a 2.5 hour movie or something like that, and then a 30 or 40 minute news reel, and these people would be sitting there in a movie theater for 3 or 4 hours. And then when they would stand up, they would have that pain from sitting for a long period of time. They stand up and engage their quad, and they get some pain. So anyway, you may read something about that, primarily just in ortho literature. You guys aren't going to be held responsible for that. But anyway, that's, and I'll put up, I'm doing this lecture from my home right now, but when I get to the clinic, I will do a posting under learning modules of the handout that I give to patients that talks about patellofemoral syndrome and has those exercises and stretches. And you have them do those for a few weeks, and it's kind of a let your body be your guide sort of thing. And as they strengthen quadriceps, that gets better. So, and this talks a little bit about you can have that positive apprehension test. Again, that's not real diagnostic, about 35–40%. Anyway, I'm not going to hold you responsible for measuring Q angles. That's something I do, but anyway. So, like I said, you get a normal examination. You're going to be sitting there stumped and befuddled. You're going to go present to your preceptor, and you're going to be, I have no idea what's going on with this. I have a normal examination. I have no clue. That we just send them off for an MRI or something. No, that's not the answer. Go back, check the history, look at the quads. More than likely it's going to be patellofemoral syndrome. If they don't improve, then you consider imaging and referral. If they do have tenderness along the joint line, the medial or lateral aspect of the patellar facet joint line, or the rhomboidal effusion, then of course we're going to work that up. So that's mainly what I wanted to focus on. The rest of this stuff you guys can read about, but again, just because it is extremely common. The rest of this, a lot of this right here with ACL, PCL, is all stuff, again, from assessment. And that's the key to musculoskeletal, especially with the knee. And that's tended to be the area that threw you guys off outside of the shoulder the most during health assessment were the special tests for the knee. So anterior and posterior drawer test, Lockman's, varus and valgus stress testing, and McMurray's. So you need to know all of that. But the rest of this you guys can kind of look through and read about on your own. But I just wanted to cover PFPS or PFS or PFP. That's how you may see it described. But again, it is patellofemoral pain syndrome.